My name is Linda Slattenger, and I'm a registered nurse with over 30 years of bedside experience, and I'm president of the Minnesota Nurses Association, a nursing union representing 20,000 nurses in our state. And I want to thank Senator Rhodes for sponsoring this very important legislation, and all of you for hearing this bill today, because we believe lives are dependent on it. In over 3 decades of nursing, I have not seen such deterioration of care as exists in our hospitals today. Nurses across Minnesota are reporting dangerous working conditions, which are putting patients at risk and driving nurses away from our profession. This problem extends to every facility throughout the state. Today, nurses face an ethical dilemma. We are bound legally and ethically through obligations to provide a high standard of care, and yet the very hospitals we work for are not held to that same standard of care for staffing. Safeguarding the public is an essential role of government, and when lives are at stake, leaving the staffing number of RNs to the individual hospitals, especially those driven now to compete for market share, is a disaster. It's a recipe for disaster. That is why we are proposing this bill that will, among other innovations, institute basic minimum statewide standards for RN staffing, a practice known as setting ratios. Nurse-to-patient ratio is nothing new to our hospitals. In fact, acute care facilities develop staffing plans that set a specific number of patients to a specific number of nurses all of the time. The problem is they do not fulfill their own ratios. When shifts are understaffed, hospital patients suffer avoidable complications or needlessly die. Research shows that for every general surgical patient added to a nurse's workload, patients' risk of death increases an average of 7%. So if I'm on a med-surg unit and I'm assigned 4 of you, I can handle that. But if I get 1 more of you, your risk of dying increases 7%. If I get 4 more of you, which is not uncommon on the night shift, you all have a 31% increased risk of dying. Current hospital staffing practices is to add additional patients to our assignment. This is their definition of flexibility. Our bill establishes a maximum number of patients a nurse can be assigned and allows improved ratios as patient conditions require. This past fall, we conducted a member survey that revealed nurses' experiences when working understaffed. You all have a copy before you. At least 80% of the nurses said communication and emotional support were skipped. Critical watching and assessment were not done, and orders and treatments were delayed. 67% said medications were not delivered on time. This means that nurses are not able to hold your hand, assess your condition, or catch subtle deterioration of your condition that could be life-threatening. Unfortunately, the current hospital ratios are based more on productivity than on patient care needs. We are told to simply make do when schedules are put out without enough nurses to fill the assignments. We are left to scramble and stretch resources to accommodate the needs of the hospital's most critically ill patients. Even worse, these staffing plans do not allow flexibility for changes in patients' condition. The bill would provide that flexibility. In 2006, MNA records show that shifts were not fully staffed 40% of the time. This is a patient neglect scenario. You will hear hospitals say they cannot meet these standards on night shifts because of nurses' unwillingness to work these shifts. We believe nurses will work these shifts when staffing is adequate. These concerns are not news to our employers, but our pleas seem to have fallen on deaf ears. Discussions in labor management committees, contract negotiations have failed to provide systemic reform in addressing chronic understaffing issues. And we find it disingenuous when hospitals proudly proclaim a list of achievements for national quality when their nurses are exhausted, frazzled, and demoralized. While the Minnesota data shows that adverse events have decreased some, they have remained relatively the same for those attributed to nursing care. Let's move beyond simply measuring adverse events to preventing complications from happening in the first place. When we achieve minimal staffing standards, not only will we reduce preventable errors that lead to injury and death, we will also reduce hospital costs by reducing length of stay, readmissions, and patient complications. Hospitals will realize additional financial benefits when recruitment costs are slashed because skilled nurses have stopped walking away from their profession. We urge you to protect all patients by supporting this vital piece of legislation. Thank you.